Hello, this is the Almonds and Weight Management webinar brought to you by the Almond Board of California. Welcome to the webinar. My name is Swati Kalgaonkar, and I am Associate Director for the Nutrition Research Program at the Almond Board of California. I have a PhD in nutritional science and an extensive nutrition clinical research experience. My primary focus is oversight of ABC contracted nutrition research, public policy analysis and synthesis, and information dissemination in support of the almond industry's global strategies. Before we get started with the webinar, there are a few housekeeping details to cover. During the webinar, all attendees will be muted. If at any time you have technical issues, please access the help screens at the top of your attendee control panel. If you have questions, please type them into the Q&A box, and we request that you do not type them in the chat box, and they will be answered at the end of the presentation. The session will be recorded and available in 3 days' time for self-study. We hope you will follow us on our social channels on Twitter, Instagram, and Facebook. Here's the agenda for today's webinar. We will start with an introduction to our esteemed speakers. They will be looking at net consumption, appetite, and food intake, and the new insights therein. And then we will be looking at a Q&A session towards the end of this session. So as I said earlier, we are joined today by two esteemed nutrition researchers. Dr. Richard Mattis is one of America's premier nutrition scientists. He is Distinguished Professor of Nutrition Science at Purdue University and former president of the American Society of Nutrition. Dr. Mattis also served on the 2020 Dietary Guidelines Advisory Committee and has authored over 285 publications. We're also joined by Dr. Stephanie Hunter. She is a postdoctoral fellow at Monell Chemical Senses Center. Dr. Hunter earned an undergraduate degree in cell and molecular biology from Winona State University, as well as a doctorate degree in nutrition science with an emphasis in ingestive behavior from Purdue University under the mentorship of Dr. Mattis.
So thank you, Swati, for that overly generous introduction, and we'll jump right in. As you said, the topic today is nut consumption, appetite, and food intake, with an emphasis on new insights. For those who follow this literature surrounding nut consumption and health effects, there are a number of findings that are now pretty well accepted. And to just summarize them quickly, the first is that consumption of nuts really has a neutral effect on body weight. That the inclusion of nuts either in a free living diet or even in a diet that is energy restricted does not lead to positive energy balance or disruption of the therapeutic goal of the diet. Second, that consumption of nuts positively impacts diet quality as measured by the Healthy Eating Index. Third, that consumption of nuts may enhance diet palatability and as a result resist monotony effects. That is, that people find them palatable and are willing to consume them on a regular basis. And finally, that there may be a special role of nut consumption in the reduction of truncal fat, and this is the fat depots. These are the fat depots that are most closely associated with metabolic health, so of particular interest here. So, as I said, those who are really closely watching the literature are pretty well convinced that this is nearing settled science. But there are many who don't follow the literature and just interact with it on a casual basis that are still quite skeptical. After all, nuts are a high-fat, energy-dense food, and for a very long time were viewed as problematic for inclusion in the diet, especially in an environment where overweight and obesity are public health problems. So let me go on to share some of the evidence base with you to substantiate the overview that I just provided. So to begin, we'll focus on the effects of nut consumption on body weight and adiposity. I'm not a great fan of meta-analyses. I think they have their limitations, but they are a very useful way to summarize large amounts of data. And that's what's shown here. This is a meta-analysis looking at trials that had body weight as the outcome of their assessment. And as you can see in the panel A on the left, down at the bottom, that triangle does not vary from 0. And what that means is that across all of these studies, there's no evidence that the inclusion of nuts in trials where they were offered without any other dietary guidance, that they alter body weight. And in panel B, the figure on the right-hand side, these are trials where there was a specific recommendation that the nuts should displace something else in the diet, for example, carbohydrate. And once again, shows that there is no effect of that kind of substitution on body weight. Similarly, this same analysis explored the effects on body mass index and found no effect in free-feeding studies or in substitution studies. And the same finding for waist circumference. No effect of the inclusion of nuts in the diet in free-feeding individuals or where there was a substitution protocol in place for waist circumference. And for percent body fat, no effect in free-feeding studies. And there was actually a very small but statistically significant benefit in the trials that used a substitution paradigm. That is, people had a slightly lower percent body fat in those protocols. And this observation holds across different types of nuts. The strongest evidence base is available for almonds and walnuts, as shown here. And what it shows, again, in a different meta-analysis now, no effect of almond consumption or other types of nuts on body weight. So a very robust evidence base indicating that nuts can be included in the diet without provoking weight gain. Nevertheless, the 2015-2020 dietary guidelines mentioned quite explicitly that because nuts are high in calories, they should be eaten in small portions. It's an interesting statement because for no other food group was this kind of warning included in the guidelines. It was only for nuts. I should point out that the most recent 2020 guidelines did not review nuts in as great a detail as the 2015 guidelines, but the 2020 guidelines do not contain this same restriction. But it's an important point because many people still subscribe to that view, even though there are other foods that have an even higher energy density, for example, oil that we include in our diets. And there the statement in the 2015 guidelines was that the amount consumed should be within 1 AMPR for total fats without exceeding calorie limits. So a much more sort of moderate and positive view about the inclusion of oils compared to how the position was stated for nuts. And this was in contrast to that very substantial evidence base that I just reviewed for you. And additional evidence that this message is not getting out. This was a survey conducted with dietitians, with general practitioners, and with practicing nurses. So people in the healthcare community that are interacting with both healthy individuals and patients and providing dietary guidance. In all three of these groups of practitioners, over half felt that nuts would lead people to gain weight if they were included into the diet. The question posed to them was, eating them will cause people to gain weight, and as you can see in the three categories of strongly agree, and neither agree or disagree, over 50% in each of those groups of practitioners apparently were not convinced by the evidence that I just shared with you. So one of the reasons that there may still be skepticism is that it's difficult to understand by what mechanism these energy-dense foods are not problematic when they're included in the diet. And over the last 2 decades, there have been a very sizable number of studies that have explored mechanisms to account for this. And I think we're at a point now where we recognize there are probably 3 components to the mechanism. And the first is that nuts have a very strong satiety value, satiation and satiety value, and as a result, they lead to strong dietary compensation. And by that, I mean that when nuts are included into the diet, people spontaneously adjust what they're eating at other times of the day to offset a good portion of the energy that was contributed by the almonds. This horrid slide is not intended for you to read in any detail, but to convey to you that there have been a substantive number of trials exploring compensation to nut consumption. And in the column second in from the right, that's the findings about compensation. And where it's green, it indicates that there was a very strong compensatory response. Yellow is no response, and red is where the response was very small. But you can see in the overwhelming majority of trials, compensation was strong. Interestingly enough, if you look in the column on the far right, that's the change in total energy intake. And there, it's not a perfect match with compensation. That is, people are either not compensating strongly for the nuts, or in fact, they end up in positive energy balance when they're included in the diet. And those were the clinical trials. In epidemiologic studies, you can see again, compensation is present in the majority of trials, but people still end up in positive energy balance. That compensation is not 100%, but it is moving in the right direction. And here's another meta-analysis that was published just recently that shows that, in fact, the evidence indicates there is a positive energy balance frequently observed when people are including nuts into their diet. So how is it possible that people are in positive energy balance but not gaining weight? So part of it is this compensation, and it accounts for somewhere in the 70–75% of the energy contributed by almonds range. But there is now emerging evidence showing that we don't absorb the energy from nuts as efficiently as one might expect based on the nutrition facts label on products, that we are relatively inefficient at absorbing and metabolizing that energy. So as we chew almonds, we include them in the diet, we chew them, they pass through our GI tract where they're hit with gastric acid and digestive enzymes. They reach the colon and are attacked as well by the microbiota there. There are a whole series of reactions that are designed to mechanically and chemically decompose the foods, the nuts that are consumed to extract the energy from them. However, the efficiency of that process is not the same as one would see if the nut was actually put in a bomb calorimeter and combusted there, oxidized there, to see how much energy is actually contained. Humans are just not as efficient as the instruments that we use to measure foodstuffs. And that's what's shown here, that there is a loss of energy from nuts in the stool, as well as a loss of energy in the form of fat in the stool when nuts are included in the diet. That's what all of the green boxes, all the studies that showed that we were not efficient at extracting all of the energy out of the nut, and so some of it was lost in the stool. We've done some modeling studies where we tried to simulate conditions in the stomach and in the intestine to see what's happening with the cells of nuts. And what's shown here is that there are intact cells in what would be the duodenal stage of digestion for walnuts, almonds, and pistachios. These are the greenish clusters, round clusters. These are cells of the nuts that have remained intact despite the digestive processes in the small intestine. And this is a micrograph from Peter Ellis's group of almond tissue that has passed entirely through a human volunteer. And as you can see, many intact cells. And so the lipid that are contained in these cells have passed entirely through this person and was not absorbed and made available to that individual. And the evidence now is suggesting that somewhere between 5 and 20% of the energy from nuts is not extracted as the nuts pass through the GI tract, that they are resistant. We don't chew them especially well, and they're resistant to microbial and enzymatic degradation. And as a result, a fair amount of the energy from nuts is lost. So that is part of the story contributing to why we can predict that people are in positive energy balance based on the nutrient label, but they're not gaining weight because we're not fully accessing the energy that the nuts contain. But there is a third part of the explanation, and that is that chronic nut consumption, regular daily consumption, may elevate resting energy expenditure somewhat and burn more energy. This has been observed in several clinical trials. This happens to be a trial with peanuts, showing that resting energy expenditure was elevated by about 11% with chronic nut consumption. And in that, resting energy expenditure accounts for something on the order of 70% of total daily energy expenditure. This increment of 11% is not trivial. Another trial has also observed an increment in resting energy expenditure, though only in individuals with obesity, not in people of normal weight. But again, it was on the order of about 11%. Now, when you put all of these three mechanisms together, the high satiety value, the lack of efficiency of energy extraction, and the elevation of resting energy expenditure, and this is done in a metabolic study, which we completed a few years ago now, what you can see is that we found 74% of the energy from the almonds, which we used in this trial, was offset by dietary compensation. About 77% was offset by inefficient extraction of energy, and 14% was due to an elevation of resting energy expenditure. And when you sum those together, it accounts for about 95% or so of the energy from the almonds. And so collectively, you can now understand how the epidemiology showed that there's no effect on body weight, and the clinical trials show there's no effect on body weight because these three mechanisms combine to offset the energy that the almonds are providing. So I think there is now a very credible evidence base for supporting the view that almonds can and other nuts can be included in the diet without exacerbating weight gain. With respect to diet quality, as I mentioned, there are findings that nut consumers have higher healthy eating index scores than non-consumers. In all fairness, it doesn't put people into a very high category, but you can see in both children, in adolescents, and in adults, the HEI scores are higher in nut consumers compared to non-consumers. Now, with respect to diet quality, I do want to make another very, I think, important point. Both the 2015 dietary guidelines and the 2020 dietary guidelines made a point of saying that if one is going to eat nuts and seeds, that they should be unsalted. Hypertension is a problem, and sodium has been linked to the onset and manifestations of high blood pressure. And so there is an emphasis on moderating sodium intake. And nuts are frequently consumed as a snack, and as a result, and are frequently consumed in a salted form. And so the guidance is to be cautious of that. But let me point out that the top 10 sources of sodium in the US diet are listed here. And even among the savory snacks, nuts are not included. They're in a different category. So nuts are not in the top 10 sources of sodium in the US diet. And of course, intake is a function of both quantity and frequency of consumption. And the frequency of consumption of nuts is not high. In this sample from NCHS, so a nationally representative survey of the US population, 60% of individuals don't consume on a given day, and 85 to 90% consume less than an ounce and a half a day. So the portion size and the frequency are very low. As a result, any sodium that would be contributed would be quite trivial. Additionally, there is a very kind of intuitive but not well appreciated point that even if we like salt and saltiness, it's not that we want to put as much of it as we possibly can on every food that we eat to get that sensation. We learn an appropriate amount on a given food and what makes it most palatable. So this is a trial done by Gary Beecham some time ago now, putting people on reduced sodium diets, but allowing them free use of the salt shaker for cooking and adding salt at the table. And what you can see is that they were on a reduced sodium diet, so total sodium intake was markedly reduced, but the amount added back, the black bar portion of this figure, was small and did not bring people back up to their baseline sodium intake. And we've done work showing that you can reduce a quarter to a half of the amount of sodium on foods without people really objecting to a loss in sensory function. And that's because when sodium is on the surface of a food, it has very ready access to salt receptors and gives a large sensory impact despite being a relatively low dose. And that would be the case with nuts. They're not naturally high in sodium, but the salt that's added to the surface is not there in high quantity, and we don't consume a lot of nuts. And as a result, they really are a trivial source of sodium in the diet. And you know, if one uses this logic of restricting the accessibility or the advisability of consuming a nutrient-dense food because it may have some other sensory property that would be of concern, then we'd be in a position of saying that we shouldn't promote milk consumption because some people add sugar to it, or it's added to sweetened cereals, or we shouldn't eat vegetables because some people put salt on them, or sources of saturated fat, or we shouldn't eat whole grains because they may be consumed in conjunction with processed meats, for example. I think we have to look at the total diet to determine what is a healthful or unhealthful use of individual foods and seasonings. Next, I do want to comment also on another, what I think is a fairly unique property of nuts, and that is the resistance to monotony effects. You all may well appreciate that if one is put on a highly monotonous diet, it may result in short-term weight loss, and it's primarily due to the fact that people spontaneously choose to eat less because food just isn't palatable. It isn't appealing to them. We have an inherent drive to seek variety and sensory stimulation, and monotony competes with that, and it proves to be the undoing of many popular diets. But there are some foods that seem resistant to this. So people, for example, are willing to eat bread on a daily basis or drink milk on a daily basis. And our observation is that nuts may have this same attribute. When we put people on research protocols and having them consume nuts on a daily basis for example, in this case, 12 weeks, and these are not people that were regular nut consumers prior to the trial, we see that they're inherently pleasant. They're rated pretty highly. But the important point is that they don't decline in any meaningful way with daily consumption over 12 weeks. This was a study where different seasonings were used. Here's a trial with almonds. So on a scale of 0 to 100 on palatability, they started off at about a 75. But after 12 weeks of daily use, they were still at a rating of 70. So they seem to be resistant to this monotony effect. And if one is then going to recommend that nut consumption be increased, which is recommended in the 2020 dietary guidelines, then this is a good sign because people can incorporate them in without finding them objectionable. And they can help with weight loss in individuals that are on energy restricted diets. The liberalization of the diet by including nuts can actually improve palatability and as a result adherence to the diet. And of course, diets only work if one sticks to them. And that's what's shown here in this study by Michelle Wien, that when nuts were added to the diet, weight loss was actually greater because people were more compliant. And a more recent trial by Gary Foster showed that after 18 months, those that were allowed to include almonds in the diet, their sustained weight loss was no different from the group that was not allowed to consume nuts. And finally, we are coming to the evidence for a really new observation with respect to nuts, and that is their specific effect on truncal fat depots. So here's one of the early trials showing that abdominal fat mass and total abdominal mass, as well as waist circumference, were lower in individuals consuming almonds on a regular basis compared to a control group. So an indication that a regular consumption would specifically tend to reduce this abdominal fat depot. And subsequent work by Japna Dillon showed that an almond-enriched diet led to greater reductions in truncal fat and an increment actually in lean mass in the almond consumers compared to those not consuming almonds. And that brings us to the most recent findings, work conducted by Dr. Hunter, and she will pick up the story from there. Dr. Hunter?
All right, thank you. So I'm going to be talking about a recent study Dr. Mattis and I did, assessing whether body fat distribution alters the metabolic response to chronic almond consumption. So epidemiological studies indicate that there is a decreased risk of type 2 diabetes with increased nut consumption, especially in women. This is data from the Nurses' Health Study, where women who consumed nuts more than 5 times per week had a significantly reduced risk for type 2 diabetes compared to women who never or almost never consumed nuts. And this was significant even after multiple covariate factors were adjusted for. Almond consumption, which is shown by the darker colored bars in this figure, improves postprandial glycemic response in acute trials compared to a control group that does not consume almonds, which is the lighter color bars in this figure, especially when almonds are consumed with breakfast, which is shown in the blue bars here, or as snacks, which is shown by the red bars and the orange bars. However, there is mixed evidence on the effects of almond consumption on hemoglobin A1C in long-term clinical trials. So hemoglobin A1C is a clinically important endpoint to address because it's a long-term indicator of blood glucose levels, and it is also used to monitor, diagnose, and treat type 2 diabetes. So previous studies have found that almond consumption reduces hemoglobin A1C compared to a diet without almonds in adults with type 2 diabetes. Other studies have found no difference between a diet that contains almonds and a diet without almonds in hemoglobin A1C. And other studies have found that a controlled diet without almonds reduced hemoglobin A1C more than a diet with almonds in adults with prediabetes. So we thought that one of the reasons for this mixed evidence of almond consumption on hemoglobin A1C stems from testing people who have different body fat distributions, who carry different risks for insulin resistance and type 2 diabetes. So the first type of body fat distribution is having a large android visceral adipose tissue, which I'll abbreviate VAT. This type of fat depot is most strongly associated with insulin resistance and type 2 diabetes. So this is a cross-section of the abdomen, and at the top of it is where the belly button would be, so that's the front side of the body. And then towards the bottom, there is the vertebral column and the spinal cord. So towards the bottom of the figure is the back side of the body, just to orient you with this figure. So the pink squiggly tissue is the abdominal muscle, and then the tan tissue is the visceral fat. So the visceral fat is located within the abdominal cavity, and it surrounds all of the internal organs. So one of the reasons it's most strongly associated with insulin resistance and type 2 diabetes is because of this location within the abdominal cavity. So it surrounds all of the internal organs, and anything the visceral fat secretes drains directly to the liver because it's connected to the portal vein. This is especially problematic because visceral fat also has reduced expression of anti-lipolytic receptors, most notably the insulin receptor, and has increased expression of lipolytic receptors. So its rate of lipolysis is less controlled, especially after a meal, because it's not responding to insulin as well. And then its location and rate of lipolysis combined make it problematic because it contributes to a high hepatic lipid content and high VLDL production, which all contribute to a state of insulin resistance. The second type of body fat distribution is having large amounts of android subcutaneous adipose tissue, which I'll abbreviate SAT. So this type of fat is also located in the midsection. So this figure is the same cross-section of the abdomen that I showed you before, but the subcutaneous fat is the darker tan tissue here. So the subcutaneous fat is less problematic for metabolic disease compared to visceral fat, in part due to its location. So whereas visceral fat was within the abdominal cavity, subcutaneous fat is on the outside of the abdominal muscle and is directly underneath the skin. So because of its location, anything the subcutaneous fat secretes drains to the systemic circulation, so it does not put as much of a burden on the liver like visceral fat does. Subcutaneous fat is also less problematic compared to visceral fat because it is more responsive to the anti-lipolytic effect of insulin, so its release of free fatty acid is more controlled, especially after a meal. However, subcutaneous fat may still carry some metabolic risks and risks for insulin resistance because it has the ability to expand much larger than visceral fat does. So subcutaneous fat, if it expands much larger, it would have more adipocytes that can contribute more free fatty acids to circulation, which can contribute to a state of insulin resistance. And then the third type of body fat distribution is having a large gluteal adipose tissue. And this type of fat is located around the hips and thighs, as opposed to the android or midsection like those other two body fat depots were. So gluteal adipose tissue is not associated with insulin resistance or type 2 diabetes, partly because of its location. So like subcutaneous adipose tissue, it also drains to systemic circulation and does not put any burden on the liver. But gluteal adipose tissue also just has a low free fatty acid flux, and it's considered an energy sink, meaning that rather than contributing a lot of free fatty acids to circulation, it takes them up and stores them as triglycerides until they are needed during periods of prolonged energy deficit. So because of these differences in body fat depots and their risks for insulin resistance and type 2 diabetes, we wanted to see if this accounted for that mixed evidence of almond consumption on hemoglobin A1C. So we conducted a 6-month randomized controlled trials in 134 participants whose BMI was greater than 27. And then we recruited participants following into one of 3 different body fat distributions. So the first group having high android visceral fat, the most problematic type of fat for insulin resistance and type 2 diabetes, the second group having high android subcutaneous fat, and the third group having the high gluteal fat, which is not associated with insulin resistance or type 2 diabetes. And we determined their body fat distribution using a combination of waist to hip circumference ratio and information from a DEXA scan. Within each body fat distribution group, we randomized participants to either the control group or the almond group. Participants in the almond group consumed 42.5 grams of almonds every day throughout the 6-month intervention, half of that with their breakfast and half of that as their afternoon snack every day. And this was equivalent to about 2 small handfuls of almonds every day, shown in the figure in the top right. And then participants in the almonds were not allowed to consume any other nuts or nut products besides the almonds that we provided them. And then participants in the control group continued their habitual breakfast and afternoon snack routines, but were not allowed to consume any other nuts or nut products throughout the 6-month intervention. And I do want to note that we recruited participants who consumed an afternoon snack of low nutrient density. So this allowed us to compare almonds as a snack compared to a typical snack that is of low nutrient density. So first we hypothesized that almond consumption would reduce hemoglobin A1C in those with high visceral adipose tissue, which is most strongly associated with insulin resistance and type 2 diabetes, that almond consumption would have an intermediate effect on hemoglobin A1C in those with high subcutaneous adipose tissue, and that almond consumption would have a limited effect on hemoglobin A1C in those with high gluteal adipose tissue. And we assessed hemoglobin A1C through blood samples that we collected at baseline and after the 6-month intervention. So after the 6-month study, we did not find any difference in hemoglobin A1C between the control group, which is shown by the white bars, or the almond group, shown by the black bars, for any body fat distribution cohort. However, I do want to point out that all of our participants had a baseline hemoglobin A1C less than 5.7%, which is considered normal. So it could be that there was limited capacity for hemoglobin A1C to decline in our participants. Next, we hypothesized that substitution of almonds for other common snacks would not promote weight gain, as the rest of the literature suggests. And after the 6-month intervention, we found no significant difference in body weight between the control group and the almond group for any body fat distribution cohort. This was true even though participants in the almond group consumed about 200 calories per day more than the control group. So our results support the rest of the literature that almonds, despite being a high-fat food, do not contribute to weight gain. And then lastly, we hypothesized that almond consumption will improve body composition compared to the control group. And we assessed body composition using a DEXA scan that we collected at 0 and 6 months. And first, we looked at the total fat and lean mass percentages. So there was no significant difference between the control group or the almond group in total fat mass percentage, shown on the bottom, or total lean mass percentage for any body fat distribution cohort. Next, we look specifically in the abdominal or the android region, which is where those 2 more problematic fat distributions were, the visceral fat and the subcutaneous fat. And we found that the almond group significantly reduced android fat mass percentage compared to participants in the control group and those with high subcutaneous adipose tissue. And almond consumption significantly increased android lean mass percentage compared to participants in the control group and those with high subcutaneous adipose tissue. But there were no differences between android fat or lean mass percentages between the almond or control group in participants with high visceral adipose tissue or high gluteal adipose tissue. So then next we looked at the composition of that fat within the android region, so looking specifically at the visceral fat mass and the subcutaneous fat mass. And we found that almond consumption attenuated a gain in visceral adipose tissue mass in those with high subcutaneous adipose tissue. So in those with high SAT that consumed almonds for the 6-month intervention, they very slightly reduced their VAT mass, but the difference was largely due to the control group gaining a lot of VAT mass. But then there were no differences between in SAT mass between the almond group or the control group, between any body fat distribution cohort. And there were also no differences in VAT mass between the almond or control group in those with high VAT or high gluteal adipose tissue. So in summary, body fat distributions did not explain the mixed evidence on almond consumption and hemoglobin A1C like we hypothesized. However, future directions should assess the effects of body fat distribution with almond consumption and hemoglobin A1C in participants who have elevated hemoglobin A1C levels at baseline. So we recruited participants who had a BMI greater than 27 that fell within one of the 3 body fat distributions. However, in participants who have elevated hemoglobin A1Cs, this would help to better address the discrepancies in the literature, especially since all the previous studies that have assessed almond consumption and hemoglobin A1C were done in adults with type 2 diabetes or prediabetes. And then we also found that substitution of almonds for other common snacks did not promote weight gain despite higher energy intake, which supports the rest of the literature. And then lastly, that almond consumption improved android fat and lean mass percentages in those who had high subcutaneous adipose tissue, which also supports the rest of the literature that almond consumption may be beneficial at reducing truncal fat mass percentage. So with that, I'd just like to acknowledge the research team from both Purdue University and IU School of Medicine, where we conducted this research. Most notably, my advisor and the previous speaker, Dr. Mattis, and then Dr. Bob Constantine, who led the team at IU School of Medicine. And of course, the Almond Board of California was our funding source, so I'd like to acknowledge them as well.
Well, thank you for watching our presentations. Hopefully you enjoyed them, and welcome to the Q&A session. With that, we'll go ahead and get started, but before we do, I'd like to encourage all of our attendees to continue to post their questions in the Q&A box. And we'll go ahead and get started. We have a really good question for you, Dr. Mattis. Do you think that metabolizable calorie estimations should be on food labeling?
Right. So this is a bit controversial and a really good question. Let me say just at the beginning, clearly having energy value information on a label is extremely useful to consumers, and I'm very much in favor of that. However, I think we have to look more carefully at how this information is interpreted by consumers. There is a sense that if it says on the package label that a product contains 100 calories, that is a specific invariant number. And that just isn't the case. As I think this audience will appreciate, the conditions under which an ingredient may be obtained, how a plant is grown, what soil it's in, what the climate is, how it's processed, all of these things alter its composition. And they are being incorporated into foods over time. And so that number is really an estimate, and there is a range around each of those values. Now, what we have learned recently is that there is also a contribution of variability due to individual metabolism, that the amount of energy each of us extracts from a food will be variable because we chew foods differently, because we have different metabolic rates, and we choose to consume foods in different combinations. Keep in mind that the primary purpose of the oral phase of digestion is to mechanically reduce foods to a level where the particles can be formed into a bolus and safely swallowed. Avoidance of choking is a primary driver here. And so those particle sizes that we are willing to tolerate will be influenced by the other foods that are consumed concurrently. So if you put a nut in a yogurt, for example, the yogurt adds lubricity to the overall bolus and allows people to swallow larger particles of nuts. The result would be that likely less energy would be extracted from the nut under that condition as opposed to if it is chewed independently to liquid form and then swallowed. So there is variance associated with individual consumption patterns, and that is now being added to the variance to the foods themselves. So the question becomes, with this added knowledge, with this greater capability to measure things precisely now as opposed to 150 years ago when Atwater was developing the factors that we use today, should we be modifying the labels? And I guess my feeling is that there is so much variability in these numbers, and we can't state any one with certainty, that it's probably within the range. And if we just interpret the labels appropriately, there really isn't a need to make an adjustment at this point. But people can use that information if it is available to make decisions on an individual basis.
That's a great answer. Thank you for that. And then a related question that came in that asked, if energy is not metabolized, do we still get the protein and other nutrients that are expected from the nut?
Yes, it's a little bit of a double-edged sword. If we are not rupturing those cell walls and extracting the lipid, we're also not fully extracting the other nutrients from those cells. As I showed in the presentation, the loss of energy is in the range of 5 to 20%. So the majority of the nutrient value is still bioaccessible, even under sort of the extreme condition here. So I'm not saying that the food is devoid of value, but there will be some measurable loss in bioaccessibility of other nutrients at the same time.
But would it be fair to say that the benefits that we see coming from consuming these nuts is obviously because of the presence of those nutrients, and it's pretty fair to say those are definitely bioaccessible, just probably not at the level they would be otherwise.
Yeah, that's my point exactly. The phenomenon we're talking about here is a measurable decrement, but not one that neutralizes the value of consuming nuts or almonds in particular for their nutrient content.
Okay, great. Thank you. We have a question here that I think could be directed to Dr. Hunter. Dr. Hunter, what are some resources to help classify body fat distribution?
Hi, good question. So we use a DEXA scan in our study. The reason for using the DEXA scan was in order to differentiate visceral fat and subcutaneous fat, so those two different types of fat that can be in the midsection. Another way, just for assessing body composition in general, for a simple way, you can do waist circumference and hip circumference. That could give you a good ratio of waist to hip circumference, and that can be associated with metabolic disease, but the waist circumference does not tell you specifically how much visceral fat or how much subcutaneous fat someone has. And if there's more visceral fat, that's more problematic compared to if there's more subcutaneous fat. So that's where a DEXA scan is good in distinguishing those two fat depots. It can also be assessed using an MRI scan as well, whatever is available.
Okay, that's great. Thank you. I guess we do have a question here. What was the ethnic background of the study subjects? And curious if any Asian subjects were included and if their hemoglobin A1C differed from other ethnic groups.
Yeah, so our participants were primarily Caucasian. We did have a couple Asian subjects, but there wasn't enough to analyze them separately. But all of our participants did have normal levels at baseline. I would have to go back and look specifically, but yeah.
Okay, great, thank you. I might just add for the benefit of our audience, I think the question might be referring to the fact that Southeast Asian and Asian phenotypes do tend to have a worse of a metabolic state and higher diabetes percentage at a much lower BMI. So we do have other studies that are currently underway looking at that as an outcome, and we will definitely keep you posted with the outcome. So thank you for that question. I think the next one goes back to Dr. Mattis. Dr. Mattis, you are very familiar with the nut and almond literature as far as glycemic regulation is concerned. In this particular study, it was very, very interesting to see, once again, significant decrease in fat mass percentage. And that's very intuitive to most folks because we understand that a decrease in fat mass should obviously mean improvement in health. But we also saw maintenance or preservation of lean mass percentage. And I'm wondering if you could talk to our audience a little bit about the significance of that preservation.
Yeah, that's another important outcome. And there are multiple levels at which this is important. First, maintenance of lean mass is maintenance of metabolically active tissue. And so that factors into the energy balance equation. The higher the lean mass to fat mass, the higher the metabolic rate, the more energy is burned on a given day. But also from a functional perspective, maintaining lean mass is important for maintaining strength and balance and just the capacity to engage in daily activities. And it really becomes a significant factor in older populations where there is an age-associated reduction in lean mass. So dietary means to preserve that would have particular value.
Thank you. And is it true that lean mass is more metabolically active, so it's good to help preserve that, and
right,
that keeps you healthy for longer, I guess?
Well, it helps to burn more energy, and it helps, as I say, with strength and balance and sort of these functional daily activity, helps to support daily activity.
Wonderful. Thank you for that. We do see a question here about whether there has been any research comparing almond butter to almonds and what some of the differences may have been. I'll take a quick crack at that to begin with, and then Dr. Mattis, if you wanted to add anything to it. We have funded research in the past looking at these different forms and, in fact, looking at heart health outcomes. And I think because of the findings we just had from the metabolizable energy study, we can explain why it was that with whole almond consumption, we certainly saw a decrease in total and bad cholesterol levels, as well as triglycerides, and a slight trend towards improvement in HDL. But with the almond butter, that improvement in HDL was actually statistically significant. So almond butter performed in all the same ways as a whole almond would in terms of reducing the bad amounts of cholesterol, but it definitely had an additional benefit of improving HDL, and that might be because its mechanically ground product is able to release the lipids that the body is then able to absorb. and then show the benefits that might come from that. So Dr. Mattis, would you like to comment on that, please?
Yeah, I'll just expand on that for different outcomes. There's quite a bit of evidence now showing that whole nuts are probably better than nut butters in terms of promoting fullness or satiation. The oral processing probably contributes to feeling full. And as Swati just mentioned, we are more efficient at extracting the nutrients and energy from butters than we are from the whole nut. So to the extent that that increment is important, there is a value there. At the same time, if one is primarily interested in managing body weight, there actually is some advantage to consuming the whole nut as opposed to the butter.
Yeah, that's a great answer. I think it really does depend on the outcome one might be looking for, and then all those forms come in really handy. Okay, so our next question, we might be going back to Dr. Hunter. Dr. Hunter, there was an improvement in android fat and lean mass percentage, as we just discussed, in those with high subcutaneous adipose tissue, but not in those with the visceral adipose tissue. And could you comment on that a little bit, please?
So we only found it in that one body fat distribution. I will say first, like the general effect of almonds on this decrease in android fat and increase in android lean mass percentage is likely attributable to their monounsaturated fatty acid content. So it's shown that can help reduce the fat percentage in the midsection. It's not super clear from our study why only those with high subcutaneous fat saw that improvement and not the other body fat distributions. I think we would need to do more research to really understand why, but it's not immediately clear why.
Dr. Mattis, would you like to add to that?
Yeah, I may just add to that. So the trial by Dr. Dillon did find benefits in visceral fat, and actually the trial that Dr. Hunter ran, it was not statistically significant, but there was a directionality to it. There was a trend for reduction in visceral fat. And you know, I'm not trying to overstate the findings or mislead anybody, but we do have to be careful about how we interpret statistics when we're looking at health outcomes. You know, I think it would be a mistake to say, well, if something was significant at 0.04, then it's real, and something that was 0.06 or 0.07 is wrong, is false. These are guides to help us make decisions to interpret data, and they're useful and they should be clearly paid attention to. But there was clearly a trend for the visceral depots as well, even in Dr. Hunter's. So, you know, there haven't been many trials of this, and I think that as the evidence base grows, my speculation, and it is only speculation, is that we will find some benefit for both of those depots. But it'll just take a more robust evidence base to demonstrate that.
Thank you, Dr. Mattis. And with that, unfortunately, we're at the top of the hour, in fact, a minute over. So we'd like to thank you all very much. We'd like to thank our esteemed speakers for presenting today. Thank you for your questions. If we didn't get to them, we will certainly get back to you individually via email. And with that, have a wonderful day. Take care. Bye-bye.
Thank you. Goodbye.